Good morning. Welcome to our virtual fireside chat on delivering better care to members with AI and advanced analytics. I'm Corinne Strom. I am VP for Cost and Utilization Solutions at Kensai. Today, I'm joined by two spectacular leaders in the healthcare industry, Eve Gelb and Kathleen McGraw. Eve is the Senior Vice President of Healthcare Services at SCAN Health Plan. She's responsible for service functions including care management, care coordination, quality management, and utilization management. She and her team strive to ensure that SCAN members receive the right care in the right setting at every stage of their healthcare journey. Before joining SCAN in 1997, she worked at Texas Children's Hospital in Houston. She holds a Master's of Public Health at Tulane University and her Bachelor of Arts at the University of California, Los Angeles. Kathleen McGraw, DNP, MS, RN, PMP, serves as the Chief Nursing Information Officer for the Microsoft Health and Life Sciences Industry team. In this role, Kathleen advises organizations on the innovative use of technology and how it can support their digital transformation imperatives for consumer engagement, provider enablement, analytics for population health, and cognitive computing to support a learning health system. She has worked at some of the premier medical systems in the United States, including Johns Hopkins and the University of Maryland Shock Trauma Center. Kathleen is a graduate of the University of Maryland with a doctorate in nursing practice focused on executive leadership and evidence-based practice. In our session today, we'll be focusing on members with high needs. These are members that often fall through the cracks of traditional healthcare systems for a variety of reasons. For example, due to underreporting of his or her limitations, due to incomplete clinical documentation or coding, or because the member is simply unable to obtain care. Advanced analytic approaches can identify these members with unmet needs where current rules-based approaches may fail. Similarly, risk-based tooling can also help to prioritize members among the ever-expanding caseloads of care managers. Attendees today will hear success stories of machine learning, natural language processing, and other advanced analytic techniques in flagging members with high needs or trends in unmet needs. The speakers will also discuss how to apply these techniques in an equitable way. Welcome, Kathleen and Eve. Good morning.
Thanks, Corinne. Thanks for having me. Good morning.
So I'm curious, I'll kick it off with Kathleen. So when you look at the vast ecosystem today of healthcare payers and health plans, how are you seeing them leverage some of these advanced analytic techniques? How are they gaining insight into the health of their members?
So it's an interesting question, Corinne, and I'll say that I'm not specifically a health payer plan expert. I do, as a clinical nurse, right, I did reside mostly on the provider side, but I've learned a lot about payers and providers, payers and plans since I've been in the informatics world. And I think that when we consider and think about artificial intelligence, it really moves us beyond business intelligence. So it realizes this idea of advanced analytics. So we're going from what happened, why did it happen, to what will happen and how can we make it happen. So essentially from hindsight to insight to foresight. And I think that because of these advanced analytics, we're really seeing that health, both providers and payers, are being led into new paradigms. And I think some of these new paradigms that we're seeing are that we're using real-time predictive analytics to shape outcomes for our patients and our members. We'll be able to provide research on demand. We'll be able to connect the many devices, Internet of Medical Things, to databases so that we can actually see the data more near real time. And ultimately, we'll be able to erase the historical boundaries for the data. So we know that the data, we're getting all this data and users want to use it, but we need to give them access to it. And we need to get them access to it very quickly. I see and I talk with organizations in both the provider and the payer space, and they want to find new ways to engage their patients and members. And this includes better understanding of both how patients and members want to engage, as well as using predictive analytics to better understand their behaviors to anticipate their needs. And I think one example is, based on my patient profile, as a patient, does your patient or your member, do they want to have an outreach via a phone call or an email or a text or, a chatbot? And we can learn about our members and our patients' preferences, and we can actually leverage that to help kind of engage with them better.
Excellent, Kathleen. I think one thing that's worth mentioning is the recent expansion of telehealth, telemedicine, and remote patient monitoring, which I feel benefits both the health plan side as well as the health system in, delivering care at scale. I've seen incredible case studies coming out at how we're offsetting more urgent and emergent care simply because we have advanced notice now that things are happening to members and patients in their home. So I'm going to pivot this question over to Eve now. So how are you seeing unmet needs in your membership today? And how are you using advanced analytics in this endeavor?
Thanks, Corinne. So SCAN is a Medicare Advantage plan. We serve seniors, although we do have a population of younger disabled folks who are eligible for Medicare, but primarily our business has been around seniors, and in fact, we were founded by 12 angry seniors in the city of Long Beach. And one of the things that we're trying to figure out is, who are the highest need seniors? But our issue is that the data that exists, in large prevalence today is really about diagnoses. And many of the frailties or the needs that our seniors exist don't come through in a diagnosis code or in a procedure code. And so what we've been trying to do is add to our data sets through health risk assessments for our entire population that are asking, core questions about social needs, particularly transportation, nutrition, housing, access to healthcare, access to medications, but also functional status, the activities of daily living. It is really hard to get from the data that exists today, identifying people who are in need of assistance with bathing or grooming, because that is really the thing that triggers a sentinel change in the life of an older adult. So we've been using models to help us identify. We know what these folks look like because we go into their homes and we complete a full assessment, and so we know what it looks like, what a person looks like, what their diagnoses and situations look like. So trying to map that back to what we could find in the data to help us identify these people earlier without having to go into the home to do a comprehensive assessment. We're also using natural language processing on our call center data, just as Kathleen mentioned, to understand the behaviors, the desires, the needs of our population. And that has been really helpful in the time of COVID to understand access to care issues. You pointed out telehealth. Telehealth is amazing. And, we're very excited that it's come this way because it transforms a human's experience of going to the doctor instead of having to, get ready for an hour drive to my doctor, pay for parking, which often costs more than my copay for my doctor's visit, see my doctor for 10 minutes and then go home. Telehealth is amazing in that it gets you to your doctor almost immediately. However, most seniors don't use telehealth and don't have access to or facility with the technology. So we are identifying through our call center natural language processing work people who are experiencing barriers to care through telehealth. And one of our concerns is that during this time, people are not seeking care when they need to because they are afraid of the in-person interaction. And so we're trying to assure and understand through our data who our most vulnerable folks are so we can do outreach and ensure that if they need to get to in-person care, we can make that happen safely.
That's pretty incredible.
I was going to say, Corinne, I love, Eve, that you're using NLP with the conversations that you're having with patients because we know that, like you said, the data is just not robust there, especially around, disparities in care and things like that. And most clinicians will tell you that you learn a lot about the patient when you're just speaking to them, not necessarily entering in data on what the patient is answering to a question. A lot of it is just anecdotal. And I talk to clinicians all the time, and they talk about the conversations they have with their patients, you know, just even things like around, for example, food insecurity. They don't actually come out and talk to the patient and say, are you food insecure necessarily? But they may have this conversation, and they may say, the patient might say, you know, I was really hungry 3 days this week and I wasn't able to get food for my kids. And that's kind of in conversations that you have with your patients. And you can learn so much for those conversations. So that's really exciting that you're doing that. I'm really excited to hear that you guys are doing that with NLP.
Thanks. We have a long way to go, but we have a great team that's focused on our customer experience that really, you know, we've dedicated in the past year or so to doing this. So it's relatively new. Before, you know, our customer service would tell us about all the issues that they were experiencing and would go throughout the organization saying, you really need to do something about this problem that the members are calling about. But now we have data to know how prevalent that particular issue is, and also to track changes over time. And so it's really been powerful in our organization as a quality improvement tool.
Excellent. And I do want to add some commentary on having worked with Eve on some of their health risk assessment data. We'd actually done a benchmarking project and seen in the literature how often are organizations making use of the ICD-10 Z codes to indicate, you know, social determinants and unmet needs. And we're finding that what's published in the literature tends to run around 2% of members have thoroughly documented their social risk factors. Eve, can you share some more insights on your HRA for All push?
Yeah, so we, as a Medicare Advantage plan, we have something called special needs plans, and special needs plans require a health risk assessment. And we found that so valuable that we decided that for our population, so about 30,000 are in special needs plans, but the remainder are not. So for our population, we really wanted to identify the issues that we were identifying through the health risk assessment for our special needs members, because we know that our seniors, regardless of what plan they belong to, have needs. And so we started, I believe in about 2018, doing a health risk assessment for all. It's, you know, it contains a lot of the short form 12 to SF12, which is a standard validated tool, but is really geared to outcomes like functional status, things like balance and falls, things that nobody wants to talk about like urinary incontinence, but also the social determinants. We decided to focus on the core ones that really impact seniors, which is nutrition, housing, and transportation. And so we've had a pretty good response rate. The survey is administered via IVR, online, or by mail. And, you know, our response rate is in the 34 percentile, which is a really good response rate. And we've really been able to identify things like when somebody indicates that they have a nutrition need, they are more likely to use the acute setting and the emergency department. So what we're trying to highlight in our population is the nutrition need in itself, which is really important, and we have protocols and interventions to address that. But the nutrition vulnerability is correlated with need overall, and so it's been incredibly powerful, and we're really happy that we've been doing it.
Thank you, Eve. So for our next question, Kathleen, what are drivers of measurement to assess how operationalizing analytics and AI is having an impact on a member or a patient's life?
So I think that it's important that when you're looking at drivers for measurement, that you look at making it personal, making it affordable, predictable, and simplifying as much as possible. I mean, when you have the data and the AI, you can actually take the clinical analytics and you can transform that into insights, as I already said. But by doing that, you're able to optimize the operations process. And because we have all these boundaries to our data, being able to erase those boundaries is really what we require to be able to orchestrate behavior change. And orchestrating behavior change is going to enable health plans and providers as well to reduce the medical cost so that they can actually have a secure, scalable, prescriptive analytics and consumer engagement platform. So I really think that when we're looking at drivers of measurement, we have to look at how will it benefit our patients and our members, and how also does it benefit the organizations.
Thank you, Kathleen. And correspondingly, Eve, how are you measuring impact on the positive health outcomes among your membership?
So, we're hyper-focused on Medicare 5-star and those outcomes. But there are many outcomes that aren't really measured by 5-star. So, for example, we have a program to support members at risk of experiencing homelessness or members who are experiencing homelessness. And folks are identified through a combination of the analysis that we do through our health risk assessment, the use of the ICD-10 code around homelessness, as well as analysis on address changes, frequency of address changes in specific addresses. And for the 73-year-old member who's living in a sober living environment with 3 roommates, the outcomes that matter to him are not his colorectal cancer screening. The outcomes that matter to him are a safe place to sleep, to be able to live in an environment where he doesn't have to perform tasks that because of his functional status, he's not able to perform in order to continue living there. And for him to feel, that he can rest his hearing aids at his bedside without them. Measure for somebody like that are much different than the kinds of outcomes that we measure for our population. So some of them are done really the work that we have to do on standardized metrics and reporting. But many of the outcomes are measured, to the point that Kathleen was making, at the individual patient level about goal attainment and really, identifying the top 3 things that are important to that individual and were we able to deliver on those goals. So I'm not sure if that gets at the question, but, that's how we're looking at things.
It does. And I think what it speaks to is the personalization that you're able to achieve, that oftentimes when I've seen, care management, care plans put into practice, there's the preset library of goals, and then there's the personal goals. And anecdotally, I've seen that a lot of those personal goals, the ones that aren't anchored to that pre-built library, tend to not only be the most successful, but also tend to be the most powerful motivators of change among membership and their engagement.
Yeah, I would agree. And I think, even with preset goals, problems, interventions, and goals, one of the tools that's amazing now that we have things like natural language processing or other tools that can really dig into the content of the notes around an individual is really to be able to identify meaningful change. So everybody might have a goal, or somebody might, multiple people might have a goal that they reach stable housing. But what stable housing looks like for each individual is very different. So being able to dig into our notes and do analytics associated with our notes is something that that we're really excited about.
I think you bring up a good point, Eve. It's really around, it brings me back to my, nursing school days, right? And Maslow's hierarchy of needs, right? Our patients, they want to have their physiological needs. They want to have food, they want to have water, they want to be safe, they want to have a belongingness and having relationships, and then as it goes up. And if you don't meet the basic needs, like you brought up the instance of safety and security, then it's very difficult to get that patient, maybe a basic screening that they may require, because it's just not something that they can concern themselves about at that point in time.
Yeah, I agree, Kathleen, and I think it's also interesting because the data around that comes from a variety of sources, right? So to the point you were making earlier, somebody might not ask an individual about their housing needs, but you can identify that they have the housing needs in various ways through the data that come from the various sources. You can also identify whether they are stable through those data sources. So, like checking a box that the goal is met is fantastic, but really, having the words of the individual saying that I feel safe, that I can sleep at night. Those are things that exist throughout our systems, and being able to compile them is really important.
Agree.
Excellent. So let's take that and turn it on its head. So we were just focused a lot on outcomes, and I'd like to look at investments. So for Kathleen, where do you think in 2021 health plans and health systems should be investing in order to make use of the vast amounts of data that we've been talking about, whether it be unstructured notes, natural language notes from call centers, or just that raw diagnostic data?
So I heard someone say today that data is the new oil, and the cloud is the new electricity, which I thought was interesting. So I'll say, I think we need to look at three things in healthcare today. We need to look at investments in data. We have a ton of data. We've been accumulating data for years now. We need to make investments in compute power, and then algorithms. So most organizations, they've already been investing and obtaining and managing a ton more data than we've had in the past. They're able to capture, store more data about their patients, about their members, about how machines perform. They're able to store, process it. The more data you have, the more accurate you can build an AI model. And that's really, where I think we need to go. The second thing is, now that we have a ton more compute available, we have a lot of different options about compute. In the cloud, we can very rapidly spin up machines, deploy a large amount of machines, or bring them down depending on the workload that needs to be deployed. And so that makes us much more flexible with compute power. And also, there's just a ton of innovative algorithms, tools, and frameworks that have been developed over the last 5 to 10 years. This is really happening because the next wave of making better applications and making more personalized services and experience is getting powered by insights gained from machine learning. So I think that payers and providers need to be looking to invest in how they can make their data of value to them. And they're going to have to do that by having the flexibility of compute in the cloud so that they can look at these algorithms and tools and frameworks.
Excellent. I completely agree. I think that the cloud is one of my favorite technologies, and this recently came up last night as well. Someone asked, what gets you most excited about healthcare IT? And I just said, it's the cloud, and it's for that quick ability to scale and for us to flight new technologies on a whim. I think that's extremely powerful. So given these technologies and given some of this investment, Eve, how is this technology helping you reach more members and potentially even expand your team?
So one thing I'd add, and I think all those things are amazing. I'm not an IT person, so I would say where we need to invest in humans, because the data, one of the things that we've really found in working with Corinne and others is that the intellectual capacity of the people who are looking at the data and their experience in real life is what really enables us to take advantage of the data, because when all of the wearables and remote monitoring first started, one of the struggles was, that you would get signal fatigue. And so that was really wasting folks' resources versus helping them. But now with the models being smarter, including all of the data and the algorithms and the new technology available there. But I think, a lot has to do with the humans who are involved in designing those algorithms. And, we're fortunate to have an amazing geriatrician that helps us go through these things, as well as, social workers who've been in people's homes for 30 years, knowing what is really meaningful about the data that's coming through and the signals that are coming through. So, I would say people should invest in people for those reasons. But with respect to expanding and scaling and making our teams more efficient, the functional status piece and identifying who might meet nursing facility level of care is super important for our organization. Our mission is to keep seniors healthy and independent, and for a lot of us, that means being able to age in place. But when folks become frail, when they have issues with their activities of daily living, they're often institutionalized. So we've worked with Corinne and her team to develop a model to identify folks who are likely to meet nursing facility level of care early in the process, to identify them so that we can get services in place. And that does a couple things. That's really amazing for the member, for the beneficiary, because they get services they need sooner. But from a staff perspective, it saves us the time of doing a telephonic assessment to find out, do we need to go to somebody's home? We can just go straight to their home. So that's really been able to help us there. We've also actually used other technology in a teleconnected way, where normally we have a social worker and a nurse who are engaged in that assessment for nursing facility level of care, but we use technology so that the social worker is in the home, brings the nurse through video visit into the home, so that there's not a separate encounter that this nurse needs to have, excuse me, with the member. It can all be done at once, and the nurse has greater insight because they see the home environment without having to drive there or do a separate visit. So, you know, I think there are lots of opportunities for how we can use technology to scale. Those are just a couple. I think also just the presentation of the data to our clinical team. So dashboards and things like that enable the clinical review prior to an encounter or after an encounter with one of our members. It's a lot, the visual nature of the displays, things like that really highlight the key characteristics to focus on, and that saves our team time. And I'd say, you know, perhaps the last example I'll bring is, you know, we've been working on different models to help target, because what we do for our most vulnerable folks is intensive human interaction. And it's really key that we save that kind of intensive human interaction for the people who really need it. So models that help us identify the true high need risk for that intensive intervention is super helpful, because it saves resources that can be used in telephonic or some sort of online interaction for the vast majority of the population. So really all of these programs that are sending people to the home, better targeting is the thing that's going to make us able to support the highest need individual and really use the resources well. So those are my thoughts.
I want to actually highlight something that you talked about early on, and this is the topic of data literacy, that all of these advanced analytic techniques are only as good as their adoption. And I think it's key that we think about staff education in marrying both what the current team knows with what they can learn from any sort of informatics-driven tool. I know that HIMSS has actually been on the forefront of this for good reason, with programs like Tiger, which is about teaching informatics through both medical and nursing education. But I think we need to expand that to social workers, to care coordinators, care navigators, et cetera, because we can throw tons of data at you, but if it isn't meaningful, if it doesn't, you know, fit into your natural workflow and speak the language that you speak, then it's just a bunch of numbers on a screen. And I've oftentimes seen in working with a geriatrician, for example, that we'll throw a pile of data on the screen and he'll say, so what does this mean to me? And that to me tells me where we can still be improving in both reaching the stakeholders in all of our engagements and in reaching more members, because we need access to the right staff member to understand this material to pass forward. So I think that there's a certain art to it, as you mentioned, in ensuring that the dashboards are very quickly understandable and that we aren't just throwing lots and lots more information out at the team.
Yeah, I think that's key. And I think, you know, social workers, community health workers, the people who are on the ground, nurses, physical therapists, occupational therapists, all of these folks, MAs, you know, they need to be supported in their work, and their time is valuable. I think we tend to focus on the highest paid individuals in our health system, but there are more of the other people. So we have an opportunity to really scale efficiency if we impact the 30 nurses associated with those 4 doctors, right? So I think you're absolutely right. And I think the data visualization is key because, you know, you put something in front of my actuary, she likes to see it in tables and tables. She doesn't really need the charts, right? But the rest of us lay folks, the charts that really point out the real, that visualize the need in a way that we can understand it, is super important. So I think data visualization, when you were talking about investing resources, I think data visualization is also a place that we need to work, because telling the story is the most important part to get somebody to do something that you want them to do.
Invariably, when we do model performance report outs, we'll show a slide with a bunch of numbers, and then we switch context to a dashboard, and that is when you can audibly hear the shift of, oh, this is where it is. This is the impact that we're hoping to have. So I agree that data visualization has been an incredible addition to the tool belt of anyone working in informatics, especially as the tooling becomes more approachable, more what you see is what you get, drag and drop. We have team members who pile into our Power BI embedded experience, and within hours, they're building out new views on the same data that we had and finding, you know, new little nuggets that we weren't necessarily looking for previously. Excellent. So this is a bit more of a challenging topic. You know, I think that the dynamics of healthcare has truly been changing, and I think that we're seeing things in the last few months that probably have been pretty pervasive in the healthcare system in the last few decades. I know, though, that at your organization, Eve, particularly, you've been really working on healthcare equity. Can you tell me about how you're using healthcare advanced analytics to ensure equity among your membership?
Sure. So health equity has been a focus of ours for a long time. But, you know, just like everything else, it starts with data. So if we don't have data around the characteristics of our population that might segment the population in ways where we can identify inequities, then, you know, all we have is anecdote and hypothesis. So we've been, one of the reasons we really launched our HRA for All was because race and language data were hard to get for us. Medicare used to send it on a file, then they stopped. We just got news that they're starting again, so we're very excited about that. But for us, we know that inequities exist related to race, related to geography, related to language spoken. So really our first step was to gather what's called the real data, the race, ethnicity, and language data, in order to see if we could identify where the disparities exist, where the inequities exist. We expect disparities, but inequities are when, you know, it's a result of some sort of practice pattern or some sort of biases or some other factor other than genetics, et cetera, that drive the differences in outcomes. So we started with our data collection, focusing on our real data. And then we've been able to develop models with some of this data to identify the inequities and the specific characteristics that drive them. So one of the things I was really surprised about in one of the models that you all did for us, Corinne, was, you know, low income was not a driver of excess hospital utilization. And it turns out that there are other things that are drivers of that. But without the data, we would have made an assumption that it was. We have to figure out, you know, why that doesn't jive with the rest of the world. But, you know, I have a feeling that it has to do with Medicaid eligibility and just, you know, the incredible access to care that comes when somebody is both Medicare and Medicaid eligible. But it's a really great example of how we can use data to figure out the real problem as opposed to the anecdote or using data that exists elsewhere and assuming that it applies to our population. So we're trying our hardest to be as honest as we can in the review of the information and to identify what we can actually figure out where inequities exist and to move from inequity to equity and then hopefully to justice, where we remove the barriers instead of figure out a way around the barriers for people, we actually remove the barriers, but there's still much more to do there.
Excellent. And so for Kathleen, similarly, you've encountered many organizations using advanced analytic techniques in treating patients or engaging with members. How are you seeing organizations mitigate bias and use artificial intelligence for fair and transparent care delivery?
Yeah, that's a really good question, Corinne. I think, Eve, you bring up a lot around the inequities and, the potential bias or what you thought you were going to find and then what the data actually showed you. I think really it comes down to we just need to do a ton more research on our AI and our machine learning fairness and the existing models that we have. We are aware of bias. I think most folks are now aware of bias. If not, we need to be aware of bias or potential bias and better understand and identify the problems prior to deploying the AI models. We need research on the new models that are appropriate for healthcare applications, and we might want to include investments in interpretable and causal models. So we know that AI is most very likely going to disrupt the health industry. So we need to have that research to be necessary to understand the differential implications for the different demographics, the different patients that we deal with, the different members, just in general, the communities that we're working with. And I think that policies and regulations really need to catch up to the new application scenarios that we're seeing if we want to prevent long-term negative impacts. We already have known issues where bias has occurred with modeling that's been utilized both by even a large insurance agency or a large insurer, and I think we really need to better understand these models. And I know that I think that I want to say the general population, folks are watching us. They're watching to, how these models are deployed. There's some skepticism to the models. I think for the clinicians that are looking at the data, they may want to know what's in the model so they can better understand it. So we need to be transparent and very clear with what's included within the model. So I think that, we need to be aware of bias and that can occur, and we need to understand how we can not have that bias and make sure that we ensure everything is done to prevent that from occurring. It's a tough problem to solve. It's not a single answer.
Yeah, Kathleen, I totally agree. And I would add the one other piece is, we do need to address the bias because folks need to trust us about giving us this personal information. Mm-hmm. We did a survey of our membership about how they feel about sharing information about race, about income, about education level, about veteran status. And for the most part, folks are okay sharing that information with their health plan and their doctor if they know it's going to be used well to improve their lives and improve the lives of others. But there's a trust issue and privacy concerns and, and questions about how that data will be used. And so I think we need to prove that we are good actors in this realm for people to trust us and be willing to share that data. One of the, SOGI data is really, interesting for us. We, in our organization and, working with older adults, it's been, we've been particularly conservative about it, but, our membership is willing to share if we use the data well. And in human-centered design and research that we've been doing, SOGI and your sexual orientation and your gender, really do impact the care you receive and also impact who you choose as your provider. And so it's on both ends. It's not just on the member side, but it's a provider's perspective and being able to make a good match between our member and their provider on many characteristics. It's not just does the doctor, is the doctor close, and do they have the office hours that they need? There's so many more characteristics now to make that good match, so that the healthcare that's delivered is the right care.
And from a purely technical perspective, I think that there's two thoughts I'd like to add here. Number one is that I have seen draft legislation that is extremely powerful and recommends algorithmic or AI accountability. And this essentially says we need all organizations who are in the trade of data and are in the practice of using data to inform or support decisions need to be accountable to avoid some of the problems that Kathleen cited in terms of either introducing or perpetuating bias. And we, as a machine learning organization at Kensai, ascribe to topics around responsible AI, or what we call FATE: fairness, accountability, transparency, and ethics. And so as part of all of our model rollouts, we always do analysis against protected features. And what's been very interesting are sort of twofold things that we see. One common issue that we see in machine learning in practice is that even if you don't feed protected features into the model, we will find other proxies for them. The model will find other proxies for them, and we have to be particularly careful to analyze outputs along the lines of protected classes. So around things like sexual orientation, ethnicity, spoken language, income status, etc., because the model may infer that. One example that Eve actually cited prior in this conversation is around use of, let's say, high-cost care, that some members may avoid certain types of care due to the cost that it may incur to them out of pocket. And that has caused historic problems in models in perpetuating some of these biases. So it's important to monitor and self-police in the way that your models may be pushing forward some of the historic disequities. And what's also been exciting for me is to see the areas where we can actually see impact already being made. And I know that we've identified particular examples where among, let's say, a key ethnicity in a specific zip code, we see the opposite recommendations being made for our models that we would have expected. So for example, we would have expected this cohort to be extremely high risk. But what's virtuous is that the model has already recognized that somewhere in the ecosystem of delivery, someone else has actually already recognized this risk. And now the model has actually seen that these members are lower risk because somewhere else upstream, someone's mitigating that. But that sort of hotspot that says, hey, we see a green circle among a larger, high risk community, we can go in and say, hey, is this expected? Is this what we would have anticipated? And then we actually can be confident that the right steps are already being put into place and then bring that to neighboring communities. So I think there's a lot of growth, a lot of research being done in this field from a machine learning perspective. And it's been my honor as a product owner to watch alongside as R&D and ethics have brought forth more powerful product solutions and the ability for all of us to ensure that we are making broader progress in 2020 and 2021. So I know we're coming up on our hour, so I'd like to move towards closing thoughts. So Kathleen or Eve, do you want to conclude with some of your thoughts today?
I'll go first, Eve, because I think you probably have more important things to say. Mine is very brief. I think that artificial intelligence as a tool is going to do a lot of good for healthcare, but we do need to be vigilant and stay patient or member focused, regardless of whether we're a provider or a payer.
Yeah, so Kathleen, I fully agree, and I think along with the data, my main point is the humans. So we are very fortunate to have our amazing geriatrician, physicians, social workers, nurses, biostatisticians to help us create the models, both internally and externally, so that they're meaningful. Because I think that, what's that term, lies, damn lies, statistics. So, we're seeking the truth. The humans are seeking the truth. And, if we are on the right side and focusing on the ethics of what we do, then then the humans are really going to help the models live up to their promise. So appreciate that.
And I think I took 3 themes away from today, from what I'm hearing from Kathleen and Eve, you both. Number 1 is we need to be doing better about making the inputs that we need. That what we see in a traditional billing environment, the diagnostic data, the billed procedure events, that's nice, but it's insufficient. That if you want more, you define and you go get more. And that's been a pretty key tenet that we've talked about today, is how can we increase the data that we are acquiring? How can we do so in a way that all of our stakeholders trust in it? They trust in both giving us access to this information and both in using it. So keep it reputable. I've also seen a theme today in terms of education and evangelism. And this can be inbound within your healthcare delivery organization or health plan. So ensuring that everyone has the knowledge that they need to be successful in using advanced analytics, but also outbound, because it goes back to that data acquisition process, that if you can explain the purpose of this data request or this sensitive information request, then you're more likely to get it. And if you can actually turn that insight into something that is shareable and impactful among a community of stakeholders and members, that you will be more successful. And then third is this wise and cautious adoption, that a healthy dose of skepticism, like Eve says, the lies, damn lies, and statistics, that's important when you are making use of any new tool. So understanding the provenance of the tool, who made it, what was it trained against? Does it truly represent my community, or is this, a model that we picked up from the Northeast and dropped into the American Southwest, where we have very different regional market patterns, regional membership domains, et cetera? Are there representative age groups, chronic condition prevalences, et cetera? And so understanding a sort of mindful adoption of these advanced analytics in both the way they were shaped and the way that they are used is also a key principle of advanced analytics. Those are my 3 takeaways. Thank you, Kathleen and Eve, for joining me this morning. It's been an honor to hear about some of the use cases that you've been working with and some of the lessons that you've learned along the way. For those attending, please look at the handouts section of this webinar for more information on Microsoft Healthcare and Life Sciences, as well as Scan Health Plan and Kensai. Thank you.